Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. Our mission is simple. We're searching for beneficial disruption in healthcare from emerging technologies. I'm really pleased today we've got two guests. Dr. Sanjay Seth, who's the Executive Vice President of HealthEC. HealthEC is a population health platform that's really been designed to elevate quality of care and patient experiencing by overcoming a lot of the healthcare industry's data challenges. Also with us is Dr. Jeffrey Lowenkron, who's the Chief Medical Officer of the Villages Health. The Villages is really a unique community in Central Florida, and Villages Health spans 8 locations and provides services to tens of thousands of patients. So, gentlemen, welcome to Tate Chronicles, and thanks for sharing your time with us a little bit today.
Thank you.
Yep.
Thank you so much.
Dr. Lowenkron, I'd like to turn to you first. The Villages really is a unique community. Tell us a little bit about that community and how healthcare is being delivered by Villages Health.
So the Villages is a 55 and older active living community, which means that 85% of the people that live here, one household, has to have somebody over 55. It also means that nobody under 19 can live here for more than 30 days a year. But it's a very active community. It's been growing rapidly. It's about 35 years old now. When I got to Florida in January of 12, there were 88,000 people living here. Now there's about 130,000 people living here, and they're growing out to about 250,000 people. Very efficient in their ability to really bring things to the community. So if you saw a plot of land and said, I'd like to put a house there, they can build you a house in 29 days. So they really mastered the ability to drive through that efficiency of building things that delight people. Part of what happened a bit back is a developer asked people how everything was going, and they said, everything's going great except for healthcare. There was a sense that care was fragmented and that some physicians may be doing things to patients in the community that may not be in the patient's best interest. So the response was to build out a patient-centered, primary care-driven, community-based healthcare model from the ground up, really to meet the needs of the patients. About 70% of the people living in the Villages are of Medicare age. And the recognition is that as people get older, they have more medical problems, and they seem to spend more time on their health care. And the challenge was in the fee-for-service world, Center for Medicare and Medicaid Services really rewards the best for 15-minute visits and taking care of only one thing at a time. And that tended to drive short visits and fragmented care, which was exactly what the patients here did not want. So the Villages decided to build out that model and recognize that the only payment mechanism that would legitimately work for that would be Medicare Advantage. So we entered into an arrangement and really found a payer that would help us to understand how we were doing. And with that, have been building from the ground up. So we've gone from 0 to 20,000 full risk lives, and from 0 to 50,000 total patients over the last 7 years.
To be able to disrupt or interfere with that fragmented nature of healthcare that we often see is remarkable. And of course, part of that underlying foundation has got to be some technology. And so, Dr. Seth, let me ask you a little bit about that, because population health management platform these days has got to aggregate claims and clinical data from many different sources. And part of the mix is clinical decision support, clinical outcomes, and even reimbursement for an organization to really achieve its goals. So tell us a little bit how HealthEC works in that domain.
So thanks, Ed. And Dr. Lowenkron is right. As the Villages grew in size, their ability to deliver care in a comprehensive, coordinated fashion required them to have data. And so that care is not being delivered on anecdotal information. And the problems that they faced with getting data from the payer that gave them a more complete or added to the picture that they had of the patient within their EMR was slow to come and difficult to read. And so that's when our relationship came into being, is the ability for HealthEC to take both the data out of the EMR or the electronic medical record that the Village's providers were using and the claim file from the payer and put that into a single place and bring to the forefront through dashboards and through alerting mechanisms that the patient that they were going to see had all these other issues that probably needed attention. And so the ability to take care of, take a holistic view of the patient was enabled through our technology. And they have had, a change in the EMR, the way that they had envisioned their first EMR vendor was woefully inadequate, that prompted the Villages to pick a new vendor. And so while the transition was going on, they still didn't skip a beat in the data that helped manage those patients.
Well, and you mentioned the data to help manage those patients. Is this also, as this data is generated and brought together and massaged, that it will identify patients who may be at risk for particular problems or diseases? Is it particular nature?
Yeah, Sanjay,
go ahead, Jeff. Go ahead.
So really what we look at is a few different things. We know that people with different illnesses will have expenditures that we hope to make on them to help keep them as healthy as they can be with their illnesses. So what the data helps us to understand is what the individual care needs are for each person, and sets it up in a way that we can make sure that we close the care gaps that people may have to help keep them as healthy as possible. So I'll give you an example. Let's say I have a patient who has diabetes, and I know that the single greatest cause of blindness preventable in the United States is diabetes. And if we take our folks who have diabetes and we can identify them and know who had their eye exam and who didn't, we have the ability to quickly and rapidly make sure that they get the right care. So when we put together a little bit of technology, both in terms of knowing who needed the test, plus the ability to do the test on site, we moved our screening capabilities from 58% to 93% in 3 months. And it's that knowing and then the ability to do something to close the gap. Now, I can't tell you whose vision we saved by doing that, but I can tell you that doing that year over year, we know that we're going to have a much lower likelihood of people losing their sight from diabetes because they were missed, and the problem typically occurs in a painless fashion.
So, let me just dive a little deeper on that, if I may. So let's say you have a patient and they have a diagnosis of diabetes, and there needs to be some screening take place to make sure that their eyes are not being affected. Does that pop up when a patient comes in and it pops up with the EMR, or is that generated on the list that's run every certain period of time? How is that notification generated? How does that data actually work?
It actually happens both ways. So there's in-reach, meaning people who are coming in, the EMR will say they're due for this. We have folks who will actively look for it. And then for folks who aren't coming in, it'll be outreach, meaning it'll be the list of people that aren't coming in who haven't had it. So we have those who have had it, those who have coming in who need it, and those who aren't coming in who need it. And that sum should be the total of all of our folks who need the screening for the year.
What has just been described from a provider healthcare side as well as from a technology side, it looks like it can work when you have a unified healthcare system. In a fragmented system, I don't know how that could potentially work. But one thing I like about what you two organizations working together is it's almost like a perfect sandbox to identify best practices where healthcare can support these outcomes. One giant area that we're moving into is the shift as far as reimbursement from fee for service to fee for value. And accountable care organization, other organizations, now they have to be involved with payment models where there's both upside and downside risk financially. What are some of the issues around that, and is this going to be a benefit to large provider organizations versus smaller ones? I know that to be successful at what y'all are doing, there has got to be a large enough organization to have IT support, technology support, and clinical support. A small practice may not be able to do that. So I'm kind of asking a two-headed question there, and feel free, either one of you, to take that on.
Yeah, well, I'll take this. Sanjay, why don't I take the size of the organization to start with, and then I'll leave all the rest of the questions to you.
Sure.
It can happen even in small organizations as long as the information is available and somebody understands they're accountable to work on it. The push towards risk really is a better way of aligning what gets paid for and patient outcomes. So the reward really is to make sure that if you take really good care of people that have multiple problems, there's a reward for doing a good job with that. If you decide to not do a good job, that's the risk. That's the downside risk of it. As long as the information's available and people understand what they're supposed to do, and it requires a lot more data analytics to be able to refine on a per-patient basis what their needs are, it's workable but challenging. For the Village's Health, as I said, we've grown from 0 patients to 20,000 risk-based lives, which is sizable. It's probably workable with as few as 1,000 risk-based patients if you're in a small practice. And clearly, 5,000 is plenty to step forward. We committed to going full risk when we started, but we also did it in steps. So we did it in a 3-year step. We started effectively with just a capitated or a per-person payment until we really understood the needs of the patients better. And then we started with something that was a little bit more shared. And then following that, the year after that, we went to full risk. The real key is to get to full risk. That's where the true opportunity lies for doing the best things for patients.
Jeff, you're right. And I think that what we are seeing is that the control over the dollar spent in healthcare really lies with the physician or the provider. And up to now, we haven't made data available at that level. Like Jeff is saying, it's one patient, one provider that the data should be made available for. Yeah, strength comes in numbers. And spreading risk comes in numbers. Because if you have 5 patients and one of them ends up in the hospital for an emergency, it could throw your total cost of care calculation out. And that prevents performance on reward. But if you spread the risk between more providers and more physicians, then you're able to manage it a little better in terms of not only the care but having the return with bonus payments. The data is irrelevant whether it's a large or small organization. Yeah, it could pose a few problems. If you had 5 organizations coming together like Jeff's entity, the Villages is, you could have 20 different EMRs and you could have 5 different payers. And the ability for every provider to track the requirements or the demands by payer, by patient becomes very hard without adding resources. And technology helps in minimizing the ground force that is required for these people to perform. So we are seeing results in both large and small organizations, but clearly from the shared savings data, it's visible that physician-led organizations, physician-managed organizations have tended to perform at a much better rate than those that are sponsored or functioning with a hospital or an insurance provider behind them. And that's the change. That's the paradigm shift that even CMS is looking for, is how do I bring accountability down to every provider level. So the size of the organization only changes a few flavors, but the dish remains the same.
Well, I think that certainly for providers who have a high percentage of Medicare patients are taken care of, they are more or less being forced into the MACRA and MIPS program, which is essentially risk-based, because they can get a positive adjustment on their Part B reimbursement, a negative adjustment, but also their MIPS score is publicly available, so there's that professional reputation side of things. So we know the government can, in some ways, mandate this move to risk, but what about third-party payers, commercial payers, are they going to follow along with this, move to risk?
Short answer, yes. Long answer,
go ahead,
I have to tell you what the time frame will be on that.
I'd love to hear it.
I think overall what people are understanding is that the rewards that have been built to date, which have been if you do a higher volume of tests and procedures, we'll reward you for those. If you think about your patients, we won't. We'll reward you if your patients go to the hospital, but if you do something really smart to keep them out of the hospital, we won't reward you. It's driven some perverse incentives. Most people, physician-wise, want to really do great things for their patients, but at times they're conflicted. I'll give you an example. Let's say that I'm running a screening colonoscopy in somebody who's 50. And basically the patient's told, this is a screening test, we're not going to charge you for it. The gastroenterologist used to get paid almost $1,000 to run those tests. Now they get paid $150. But if they do a biopsy, they get $800. So now you're in there, you see normal mucosa. You're allowed to biopsy it to look for submucosal ischemia, meaning the layer that you're biopsying looks normal, but just underneath it may be abnormal.
Yes.
If you biopsy it, we'll reward you with $800. So now the physician is getting a signal. We really want you to look for this unusual problem, even though it looks normal, because that's why we're rewarding you for it. That's why they'll interpret it. For the patients, most of whom don't have that problem, I can tell you the biopsy is all risk and no benefit, even though the risk is relatively small. And how do you align those perverse incentives? Really the best way is to try to figure out how do you reward people if their patients do better.
At the same time, you can't make the formula to calculate the reward too complicated. It's got to be simple enough to be understood and straightforward enough from the data. It shouldn't require, a master's degree in math and statistics to figure out whether you're losing or staying ahead or you're falling behind. And I think that's where technology can help, is where you take a dashboard that includes the reward calculation based on the metric, and eventually the providers just rely on the dashboard to look and see where they are in terms of a benchmark and what are the 5 things that they can do to make a difference or move the needle. I think that's if a platform can deliver that information in a simple visual graphic, one screen that the provider can get or alerted with, then you see the behavior change. Otherwise, it's hard to see what to do. So it's got to be actionable, and it's got to be in summary form that gives the provider the ability to drill down and say, wait a minute, why this patient is being recommended for that, and leave the clinical judgment to them individually. But prompting that direction or putting that arrow up saying go this way is where technology can help.
Completely agree.
Well, it seems like the definition of patients getting better or patient outcomes to a certain degree is identified by how a particular provider ranks with their clinical quality measures that they're reporting. Are there some other ways that data is used to try and identify the quality of care that might be more accurate?
There are many ways to define quality, and the industry standard has been to measure it through these quality measures called HEDIS, or for physicians, it's also a MIPS metric. So the industry is defining some of that. Now, clinically, we could disagree with the quality metric, but they're looking at the population or the nation as a whole. I'll give one example that Jeff was just using in diabetes. The HEDIS measure for diabetes is to make sure that no patient has a blood sugar over 8 in their HbA1c measurement, and some payers are at 9. Clinically, we manage those patients, and Jeff, you agree with me that you manage patients under 7. So is managing a patient under 9 good enough for quality, or should it be 7? And I think that's just a maturity process for the whole industry to move to sometimes not just measure for measuring's sake, but actually put some meat on the metric to say improving quality or outcomes.
Sure.
Yeah. So I agree with that. So the difference between 7, 8, and 9, for diabetes and hemoglobin A1C, 9 is really where everybody agrees is poor control, 9 and above. There's a fair amount of evidence that shows that even less than 8, most complications are avoided. Well controlled is typically 7, and some try to manage to 6.5. So what Sanjay is saying is exactly right. People are all over the map. But the way I would answer your last question is the way that the Villages Health has approached it is we've acknowledged that even if we had 100,000 patients, we're still really relatively small. So payers and CMS, they have hundreds of millions of patient years worth of information. They have a lot more information than we'll ever have. What we had to do, and it's a bit uncomfortable at times, is we've committed to acknowledging that they'll know better from a data perspective how to define quality than we would. We typically want to define quality as all those things that we're doing great with. But I think if we're fair, we would say if we let somebody who's not us tell us what quality is and then we respond to it and build the agility into the system to make sure that we address and achieve that quality, the patients will be better off. And that's the approach we've taken at the Villages Health. So others will define quality and will respond to it.
We only have about 4 or 5 more minutes before we run out of time. I'd like to ask, I imagine what's essentially an administrative question, Dr. Lowenkron. As the Villages moved to a risk-based model, was it difficult to get physicians to buy into that model, or what were some of the challenges, and how did you address them?
No, so there's 2 pieces to it. The decision was an easy one because that was the way the model was designed initially. So remember, I said the key was that the concerns that came up drove us to acknowledge that the way to build the model was around time with patients. So patients needed to be able to get their stuff done. We committed to more time between the doctor and the patients, which means smaller practices and all that other stuff that goes along with more time for patients and doctors. The only way to pay for that, payment mechanism-wise, was Medicare Advantage. That's the only thing that existed that allowed for that. The only way that really works well is going to full risk. That's the long-term play for it. It's where people are pushing us to, and we just embraced it and said, we understand what you're telling us to do. And we designed the system to deliver on that. What was new for the doctors was to understand what information gets generated and how do you define doing a really good job. And that part's new and we're still learning it. So one of the measures might be for your practice, what's the admissions per 1,000 patients that you have? And where should that number be and where is it? And then more importantly, what can you actually impact? So the ability to impact something, there's lots of stuff we can measure that we can have no ability to impact it.
Sure.
The key in risk is to figure out on the margin, where can you have impact? And for that, we're still learning. But our folks are committed to learning. It's part of our core competency and part of our core values. But we hired people in with them understanding we were going risk.
Go ahead, Dr. Seth.
There could be a different scenario where how do you get skin in the game from the providers?
That's my question. Yeah.
And I think that's a challenge always. They need to first believe, like Jeff is describing, they have to believe in the process or in the program. Then getting skin in the game is not difficult. Getting them a success story to lay the foundation is a way to gain some credibility and then getting skin in the game. So relying on altruistic nature of all of our providers is not the only thing that could drive all of this. There has to be some skin in the game. Again, it depends on the organization. And we talk about what is the culture of the organization. And so Jeff is right. Recruiting the right folks with the right concepts up front gives you a far better opportunity for success than taking on people willy-nilly and using 1 or 2 carrots or 1 or 2 sticks. And that that makes life difficult to manage. It's not that it's not possible, it just makes it difficult to manage. So the culture of the organization is far more important than all the sticks and carrots we could.
You know,
Yeah.
and I
Can I say one thing?
Sure, please do.
I completely agree with what Sanjay said about that. So our compensation model is predominantly salary for an expected amount of work, and the upside potential is all linked to outcomes for patients, not to volume. Because if you tell them, listen, you have a volume expectation, and then you tell them we don't really want you to have a volume expectation, they recognize that both we're confused and then they're confused.
Sure.
The using RVUs is a great example. You end up with patient churn. The same patient is called back over and over again in the game to bring their RVUs, which is volume, up. And so you have to design your compensation methodology carefully. And when you're dealing with providers and not an organization or an employed situation, it gets much harder. And you have to be much smarter, both in making sure that you're not leading them by the nose. At the same time, you're giving them the tools to understand where they currently are and where they need to get to.
Well, I think that is a perfect place to leave it for today, gentlemen. Our time has really flown by. I want to thank our audience for joining us on this episode of Tate Chronicles. I offer a special salute to my guests, Drs. Lowenkron and Dr. Seth. Thanks for coming aboard today, to both of you. I appreciate it very much.
You're very welcome.
Thank you.
You can find more information on this show's program page at healthcarenowradio.com. And if you want more information about HealthEC, you can go to their website, HealthEC, all one word, .com. And as far as the Village's Health, you can go to thevillageshealth.com. So either one of those. So until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.